This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the videos or materials may only be undertaken with the prior written consent of the AARC. Copyright 2020, all rights reserved. My name is Tim Myers. I am a registered respiratory therapist, neopediatric specialist, and chief business officer at the AARC. I welcome you to today's presentation. Initial Modified Pulmonary Index Score predicts hospital length of stay for asthma subjects admitted to the Pediatric Intensive Care Unit. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Ms. Dana Evans. Ms. Evans is a registered respiratory therapist and a neonatal pediatric specialist. She is the Director of Respiratory Care at Ann and Robert H. Lurie Children's Hospital of Chicago. She is also active with the ARC, serving as a Director at Large on the Board of Directors and on several committees. Dana has no financial relationships to disclose. I disclose that I am a paid employee of the ARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dana, welcome to the program, and the floor is yours.
Thank you, Tim, and thank you for having me here today. I am really delighted to have this opportunity to discuss this month's Editor's Choice in the Respiratory Care Journal. As Tim said, this article is called Initial Modified Pulmonary Index Score Predicts Hospital Length of Stay for Asthma Subjects Admitted to the Pediatric Intensive Care Unit. This is a really great study with some great takeaways, I think, for not only pediatric providers, but respiratory therapists in general. So let's begin by talking about the research question that was addressed by the authors. The authors' institution had previously utilized a bronchodilator protocol, and as a component of that, they were using a modified pulmonary index score as part of that pathway. In this study, they specifically sought to evaluate if the MPIS, the Modified Pulmonary Index Score, can predict hospital length of stay for patients admitted to their PICU that were managed on that standardized clinical pathway. So with any research question or any research paper that you're reading, it's always important to think to yourself, is this research question relevant? i.e., do I want to read this article? And in this case, yes, I think it is a very relevant question to ask, and this type of work in particular can be quite helpful in assisting caregivers, respiratory therapists, physicians, et cetera, in clinical decision-making and identifying where patients should be placed, can they be managed outpatient, should they be inpatient, et cetera, as well as serving to identify potential future research initiatives. So as anybody who works with kids know, because they're small and sometimes have challenges following directions, they're pretty unreliable and unreliably able to perform peak flow and FEV1 measures and other techniques that are traditionally used to predict asthma severity in the emergency department and in the ICU areas. So we know that those are commonly used, but sort of being unavailable or not readily predictive in children, other techniques are often needed to predict illness severity. So this means alternate tools should be identified in order to properly care for kids with asthma, and the MPIS is a potential tool that might meet that need and close that gap. For this reason, the authors did integrate the MPIS into their asthma protocol, allowing them to score severity and make decisions regarding care, both escalation and de-escalation of bronchodilator therapy in this case. Many children's hospitals do use a scoring tool in the care of children with respiratory disease, and most commonly with asthma. Several of them use MPIS, but there are a myriad of scoring tools out there, as it has become quite commonplace to have a scoring method in place when implementing pediatric asthma protocols. So let's take a couple minutes here and look at some of the previously published work specifically related to the Modified Pulmonary Index Score and pediatric asthma exacerbations. So the first study we're going to talk about is this one by Carroll et al., Modified Pulmonary Index Score with Predictive Value for Pediatric Asthma Exacerbations. This was published back in 2005. And in this work, the authors sought to test the reproducibility, often referred to as inter-rater reliability, and the clinical validity of the MPIS. This was a single-center, prospective analysis of pediatric patients admitted to the pediatric ICU or the general care area. This is not a large study, a smaller study with only 30 subjects actually enrolled. They did, however, find that the MPIS is reproducible among healthcare providers and is a valid indicator of severity of illness in children with asthma. So looking at this next slide, you can see this is the slide that is visually demonstrating the inter-rater reliability or reproducibility between caregivers. As you can see from this, they looked at the inter-rater reliability between physicians and nurses on the upper left-hand side, physicians and respiratory therapists on the right-hand side, and then the lower is the comparison between nurses and respiratory therapists, each dot representing a MPIS score conducted by one of the caregivers, and you can see all of those dots are very closely aligned, indicating that there is high reproducibility amongst each of these disciplines, because you can see they got similar results in their MPIS score when conducting the assessment on the same child in the same time frame. So reproducibility or inter-rater reliability, whatever you prefer to call it, are very important when you are looking at scoring tools like this or any other clinical indicator. When you have high reproducibility, it means that you would get similar results regardless of who is conducting the assessment. So if a tool does not have high reproducibility, if I were to do a score and Tim did the score and they were grossly different, it would be really difficult to maintain standardized, protocolized care for patients, because the choices I would make based on my score would then be quite different for Tim if he had a different score than I did. So high inter-rater reliability is vital and really the first step in determining if you can use a tool to ensure standardization of approach. So as I said, inter-rater reliability is important, but it doesn't really matter if the tool cannot be validated against the measure of illness. So it has to be both things. So this study also sought to ensure and to evaluate the validity of MPIS in pediatric asthma exacerbations. You can see from this slide that higher scores positively correlated with an increase in hospital length of stay. So children with lower scores had lower length of stays than compared to children with higher scores. In this case, they looked at 12 as kind of the break-off, so less than 12 or 12 and greater. You can also see it correlated positively with a longer need for oxygen therapy. So they were on oxygen longer if they had a higher score, and they required longer time on continuous bronchodilator therapy when they had a higher MPIS score, as well as had a higher likelihood that those patients would require admission to the intensive care unit. So this would suggest that the tool is not only reliably reproducible, but is also a valid predictor of illness in this particular patient population. This next study, Usefulness of MPIS as a quantitative tool for the evaluation of severe acute exacerbation in asthmatic children, was published in 2015. This study, again, also sought to evaluate the usefulness of this tool, MPIS, in children with asthma. Like the previous study I just mentioned, this was also a single-center prospective analysis. The team used a convenient sampling method of all patients under 15 years of age admitted with asthma. And to evaluate inter-rater reliability, they did a little bit differently than the previous group did. They actually randomly selected patients from the pool of 87 patients that they had pulled to look at the data, and had 2 physicians and 2 nurses simultaneously score the NPS tool on 7 different children and then compared those scores on those random children. So again, this is a little bit less rigorous than what the previous study did, but it did have a similar outcome. So when the results were compared, the scores were very close demonstrating high inter-rater reliability. I didn't include the graphics on this one, but they look virtually identical to the graphics that I showed you on the previous study demonstrating high reproducibility. This group also found, like the last study, that higher NPS scores positively correlated with a longer length of stay in the pediatric intensive care unit. And this next study, Clinical Utility of Modified Pulmonary Index Score as an Objective Assessment Tool for Acute Asthma Exacerbation in Children, published in 2014, had a much larger sample size than the previous two we talked about. This was a single center retrospective review that also included a convenient sample of all patients admitted with acute asthma over a 2-year time period. So much larger sample size. They sought to evaluate the validity and predictive value of the Modified Pulmonary Index Score in children. So this is a figure from that study, as you can see from the table. Just to orient it to you a little bit, this is looking at admission and non-admission of children that presented to the ED and received an NPS. So the dark gray or black boxes represent admission to the hospital, and the lighter gray representing discharge, so non-admission. This is also vetted out in numbers down below if you're not a visual person. So it did find that higher NPS scores positively correlated with admission rates. So the higher your NPS score, the higher the likelihood that you would require admission. So you can see as you get further and further to the right here on this graphic, you can see the line becomes more and more black, indicating that more patients were requiring admission to the hospital as compared to those with lower NPS scores. So the authors, based on this information, you can see below that those were statistically different. Oh my goodness, I'm stumbling. Statistically significant differences in admission versus not admission with a p-value greater than 0.0001. So the authors concluded that this demonstrated that the NPS was a validated tool for predicting illness severity. So based on what we've seen here in these last 3 studies, we could say that the Modified Pulmonary Index Score in children with acute pediatric asthma exacerbation is both reproducible and a validated tool for predicting illness severity in those kids. Okay, so we've been talking about the NPS. You might be wondering, what is that thing? So here is the Modified Pulmonary Index tool. The NPS evaluates 6 different parameters. So pulse oximetry, accessory muscle use, inspiratory to expiratory ratio, the significance of wheezing, heart rate, and respiratory rate. And you can see that in both heart rate and respiratory rate, that's broken down a little bit further by age group. I think we all know that younger children just naturally have a higher heart rate and respiratory rate, so those normal ranges are a little bit different, so that's broken down here. Patients can receive a score between 0 and 3 in each of these 6 categories, with the maximum score, if you scored 3 in each area, being 18. In the study we're talking about today, the institution used NPS for initial assessment and management of their bronchodilator protocol. So upon arrival, they did an initial NPS, and then with each subsequent interaction, the respiratory therapist does another NPS to determine the need for weaning or escalation of care in their bronchodilator protocol. Before I move on to the methods section of this paper, I do want to talk just briefly about conflict of interest. So again, when reading published research, there's a lot of things that are important to evaluate. One of those is the conflict of interest for the authors. While it may have absolutely no relevance on the findings, it's always important to be thoughtful about it and about research being conducted by those who may have a financial or other vested interest in the potential outcome. In the case of this work, the authors do not report any conflict of interest related to the subject matter, and there are no corporate sponsors or any companies that would have a clear direct benefit from the outcome of this work. Okay, so what is the study design? This is a single center retrospective chart review. So retrospective chart reviews are really quite common and are used to evaluate what is known or believed to be known in healthcare and is often used to validate data. It's typically used to establish information in preparation for future prospectively designed studies. The reason we would prefer, when possible, prospectively designed studies is retrospective studies sometimes have the inability to control for certain variables, whereas in a prospective study, the researchers can have more control over the adherence to a research protocol. So for example, with a retrospective chart review, you can pull all the data points, but it's impossible to know the details around everything that was happening in the moment with that patient or in the organization. And it's a little bit impossible to sort of piece together everything that was happening at that time. And sometimes variability can be introduced. Sometimes you can see it and sometimes you can't. So retrospective reviews are very, very common, and they are fabulous in terms of trying to identify and validate data, but they do have some limitations. They're also pretty inexpensive and simple to conduct relatively. So we can learn a lot from retrospective reviews. So what was the inclusion criteria? So again, the authors used a convenient sampling method and included the charts of all pediatric patients aged 2 to 17 who were admitted to the pediatric intensive care unit with a diagnosis of asthma. This was over about a 3.5-year period between June of 2014 and November 2017. So that was shortly after actually they implemented their pediatric asthma protocol in 2014. They ultimately ended up getting 143 patient charts that were admitted to their PICU. So I've mentioned it a couple of times. I just thought I'd take a moment to define what a convenient sample is. So a convenient sample is the most common sampling method for retrospective reviews and was used in all of the studies that I've talked about so far. So a convenient sample simply means that the research team selected all suitable cases over a specific time frame. So in the case of this study, every single pediatric patient with asthma that was admitted to the PICU between June of 14 and November of 17 were included in the data set. So it sounds more complicated than it is. What is the control group? So there was no clear identified control group or comparator group for this. So this is really just looking at the data they obtained from those 143 patient charts. Is the sample size appropriate? I would say yes. It seems like this is a pretty reasonable sample size to answer the research question. However, there was no specific mention of a power analysis, though I will say the study does look like it's adequately powered. Now, I will mention that if you scour the body, like I said, if you scour the body of the paper, you won't find any reference to the words power analysis anywhere. But we know the authors were at least thinking about a power analysis and really looking at this because they described their chosen alpha level. And in this case, their alpha level was 0.05. And in this case, and as is true in virtually every publication, the authors deemed an alpha of less than 0.05 is statistically significant. I'm mentioning this because alpha levels directly direct the number of patients that need to be included, so it informs the sample size in order to achieve statistical significance. So hence, looking at their alpha level, it leads me to believe that the study was adequately powered. So was the statistical analysis appropriate? Yes, the authors analyzed their data using SPSS with non-parametric chi-square, and one-way analysis of variance performed. And then they snuck in a Poisson regression analysis because the length of stay data was non-normally distributed and positively skewed. So that analysis looks specifically at PICU admission factors, and we'll look at that table and talk about that a little bit more in depth in just a moment. So as we continue to discuss the methods, I think it's important to pause and talk about this bronchodilator protocol, as all of these children were on it during the study period time. There are some items that were components of care for these kids that were protocolized as standard, and others that were left to the physician or nurse practitioner to their discretion. So bronchodilator frequency is managed by the respiratory therapist. Autonomously and independently, they are able to increase or decrease the frequency of those inhaled medications based on the modified pulmonary index score. Heliox and IV MAG are administered if the patient has an NPS of 12 or greater. And all patients, regardless of their score, received systemic corticosteroids every 6 hours. It was also true that any patient that required continuous albuterol therapy for more than 4 hours was automatically admitted to the PICU, so those were all standard and consistent throughout. However, high-flow nasal cannula and non-invasive ventilation are not part of the protocol, so those are ordered independently by the provider. So for that reason, in all likelihood, there's some variation in practice from one provider to the next. And it may create some limitation and variability in this work and the findings. During the chart review, 12 data points were collected for each patient. You can see those here: age, weight, gender, medical history, cause of exacerbation, the route of admission, did they arrive via ambulance, the ER, did they transfer from the ward, etc. The respiratory support they were requiring admission, were they a PICU readmission? So had they been previously discharged and were returning for care? Vital signs, the NPS, the length of time on continuous albuterol, and then the overall length of stay. So we already looked at the NPS tool, but I wanted to point out that the protocol defined severity of illness in 3 different levels. So the authors of the story are working on 3 different illness severity levels: low, medium, and high, with children designated as having a low illness severity if their NPS score ranged from 0 to 5, a medium severity for scores 6 to 9, and a high severity of illness if their score was 10 or greater. So as I mentioned before, during the study period, they did identify 143 subjects, and those were all included in the chart reviews. So we're going to talk about their findings now. So here is the table. So this is a pretty busy table. I'm going to break it down, though, a little bit so it's easier to see and follow. So each of the items on the left are broken down based on the NPS score, and those are separated out by severity level. So you can see the green box is all the data related to children who had low illness severity, yellow for medium, and P for high, and red for high. And then all the way to the right-hand side of the table is the p-value, demonstrating if that information is statistically significant. So I'm just going to blow up each section so it's easier to read. As you can see here, there was no difference in demographic data, age, sex, or weight. All the p-values did not reach statistical significance. So this means that age, biological sex at birth, and weight have no impact on modified pulmonary index scores. The same is true for home medication and for previous medical history. They have no impact on the NPS scores. You can see that demonstrated by the high p-values on the right-hand side. So it didn't matter if they were taking medications at home or not. This is all about what they looked like when they presented to the ED. And then again, there was no correlation here between the cause of exacerbation or anything else either. So you might be asking yourself, well, what does it correlate with? Well, higher NPS scores did correlate with some pretty significant things here. So it correlates with a higher need for the use of high-flow nasal cannula therapy and a higher need for Heliox use. You can see both of those being statistically significant with the p-value less than 0.001. It's interesting that that didn't hold true for non-invasive ventilation. If you look at this, you'll note there were 2 children in the low category that ultimately that were on non-invasive ventilation. The authors pointed this out in their discussion, that those 2 subjects in the low severity group were placed on NIV, and then they also mentioned that both of them rapidly weaned off non-invasive ventilation and discharged from the PICU pretty quickly. So this definitely had an impact on evaluating whether or not NPIS would be effective in predicting the need for non-invasive ventilation. But I think this probably also highlights that NIV was not protocolized and was managed by provider's discretion. So this may be one of those variables that gets entered in based on provider discretion, but it did show a positive correlation with high-flow nasal cannula therapy and the need for Heliox. As you would expect, respiratory rate, oxygen saturations, and FiO2 were significantly different among the groups. This should be expected because you may recall they're all actually components of the NPIS score with those values directly correlating to higher points being awarded. While it's interesting that respiratory rate, again, it also is not statistically significant despite it being a measure in the NPIS. So functionally, that means there was no difference in this measure among the groups. So whether or not you were low or high, your heart rate, while all the children were tachycardic, it was not a big jump from one group to the next. So no significant increase from the others, but the others did have statistically significant growth as one might expect. So this is some really interesting data as well. Huge, significant impact on overall hospital length of stay, PICU length of stay, time on continuous albuterol. So it seems totally reasonable, and I think we would all agree, sort of intuitive to think that sicker children are going to have a longer length of stay and need higher levels of intervention. So we all know that intuitively, but what this actually demonstrates is that the initial NPIS can accurately predict that this is going to happen. So it can predict which children are sicker and are going to likely need longer hospital stays and greater intensity of intervention to support them. So these 2 figures just give you another way of looking at length of stay in a visual manner. So the 2 tables clearly show a direct correlation between NPIS and length of stay, both in the PICU and overall in the hospital. So you can see with the left-hand side looking at hospital length of stay and the right-hand side looking exclusively at PICU length of stay. As you sort of traverse from left to right, looking at low, medium, and high, the length of stay rises up on that chart. So as I mentioned briefly when we talked about statistical analysis, a Poisson regression analysis was conducted. So you're looking at the results of that here in order to evaluate and identify factors that might predict PICU admission and what was associated with the need for pediatric ICU admission. So in this analysis, they chose a reference point. So the way this type of regression analysis works is you choose a reference point from your data set and you compare others to that reference. So in this case, data from the low severity group, NPIS of 0 to 5, is listed as the reference group. You can see reference written next to those, next to that category on here. So after adjusting for demographics and medical history and doing this analysis, they identified the incidence risk ratio for hospital length of stay in these patients and found that for children in the medium category with an NPIS of 6 to 9, the incidence risk ratio for hospital length of stay was 2.09 in that medium group and 2.68 in the high severity group. So what does that mean? So just in plain terms, what that really means is when compared to children in the low severity group, kids that scored in the medium severity group are at 2.09 times higher risk of being admitted to the PICU. While those in the high severity group, again compared to the low severity group, they had a 2.6 times higher risk of needing PICU admission. So again, just further supporting that the higher NPIS scores are correlative with the need not only for PICU length of stay, but in this case, PICU admission in general. So intuitively, again, this should make sense. Patients that are sicker would be more likely to require PICU admission. So this also suggests that the NPIS score can predict which kids are going to need PICU admission based on score. So no other factors listed below that. You can see admission route, cause of exacerbations, home medications, and history of ICU admission were all looked at in the same fashion. None of them have a significant impact on whether a child would require PICU admission. So just the NPIS score seems to be indicative of that. Okay, so what do these findings mean? Well, it means, as I've said, the initial modified pulmonary index scores directly and positively correlate with overall hospital length of stay, PICU length of stay, and the time required to be on continuous bronchodilator, inhaled bronchodilator therapy. Higher NPIS scores were also predictive of a higher likelihood to need to be admitted to the pediatric intensive care unit. And as we saw, children with higher NPIS scores were also more likely to require high flow nasal cannula therapy or Heliox administration. How do these findings relate to previous findings? So as we talked about those 3 studies at the beginning, this really supports and amplifies that work a little bit that's been previously published and supports the ongoing work of the respiratory care team in this institution using this protocol, that it's positively predictive and can be useful in supporting patients with status asthmaticus. What are the limitations? We've talked about these a little bit throughout as well. This study does have some limitations, as all studies do. This was a single center review, which sometimes can make it difficult to know whether or not the results would be generalizable to other hospitals. Because it was a retrospective review, as I mentioned, it's impossible to control for variability that may have occurred or differences in protocol adherence retrospectively, as opposed to being able to control that moving forward. The decision to initiate high flow nasal cannula and non-invasive ventilation were not protocolized. Those were managed by the provider, so would not necessarily be known to correlate with an NPIS score. I think we showed in the research that the higher the score, the more likely you need some of those things, but it's impossible to know if the physician standing at the bedside was aware of the NPIS score and used that to drive their use of high flow nasal cannula or Heliox therapy or non-invasive for that matter. The authors did note, and I hadn't mentioned this before, some issues with their PICU discharge factors. So PICU length of stay is affected by bed availability on the wards. So I think we all know that if there is no open beds on the floor, you can't transfer out of the PICU just yet, and you have to wait for the child to be discharged or the room to be turned over so that they can leave the PICU. So that can cause a child to remain in the ICU longer than is medically necessary. So that may have had a negative impact on the length of time kids were in the PICU. Additionally, there were no standard criteria in place for determining when a child was ready to be transferred to the floor. So again, introducing some variability in the outcome here. Finally, the authors mentioned that because they had been using the modified pulmonary index score with some success for a period of time, particularly over that 3.5 years, probably getting stronger with it, it may have created some self-fulfilling bias amongst the care team, with them being more aggressive in the treatment of patients with higher MPIS, particularly for those non-protocolized things. They may have jumped the gun a little bit and started using high flow, for example, if the score was higher, because they knew that those children were more likely to need more aggressive therapy to be supportive. So again, because that wasn't strongly protocolized, you can imagine some variability being in place there. What additional work is needed in this area? So some additional prospective studies would be great to confirm the findings of this data, so we could have a little bit more control over the study protocol. And it would be beneficial perhaps to see if the MPIS could have a similar impact or similar value in other diseases. So for example, could this be something that could be utilized for a cystic fibrosis example or exacerbation, for example, or bronchiolitis or pneumonia in guiding and understanding illness severity and the need for types of supportive care. This issue of the Respiratory Care Journal not only included this article, but this accompanying editorial written by Michael Davis. So I want to take a few minutes and talk about the content of this editorial. Using predictive scoring systems for asthma exacerbations could help safely conserve resources during the COVID-19 pandemic. So right out of the gate, the title of this caught my eye. So the author of the editorial acknowledged that over the years, as we said previously, there have been a myriad of scoring tools used to identify severity of disease, changes in disease, and perhaps they can predict outcomes. Several studies, including this one, have found that the MPIS positively correlates with length of stay, illness severity, and is reproducible amongst different caregivers and healthcare providers. This supports the idea that MPIS may be a useful tool when evaluating patients with asthma exacerbation. The study also demonstrated that the MPIS can positively predict the need for high-flow nasal cannula, and that says NIV, but it should say Heliox. I apologize for that. High-flow nasal cannula and Heliox in this patient population. Mr. Davis also had a very interesting take on this article. As you saw from the title, he was thinking about how this study might inform the care of patients with COVID-19. Noting that particularly during patient surges and moments of resource overload, that typical triage methods may not be effective. So with an increase in remote treatment and monitoring, objective metrics that predict disease severity, course of illness, and length of stay could be beneficial in determining which patients need to be admitted, while other patients might be able to be cared for as outpatients. So this could reduce the patient's exposure to COVID-19, while also reducing the overall burden on the healthcare system, which is kind of an interesting thought. The authors also discussed, Mr. Davis also discussed that more studies are needed for predicting usefulness of MPIS in pediatric patients beyond asthma exacerbation, and wondered if this could be translated to patients that have cystic fibrosis or even adult patients with COPD. Predictive tools like the NPIS could help the healthcare team safely conserve scarce resources and allocate those to patients who are most in need while balancing ensuring our patients receive exceptional care and the support they need and maintaining all of our resources in the course of the pandemic and beyond. So moving back to the research paper and the author's conclusions. So as we've said, the authors concluded that the NPIS score can accurately predict both hospital length of stay and pediatric ICU length of stay, as well as the intensity of therapy that would be required for all asthma patients submitted to the PICU. They further concluded that the initial NPIS might be used to assist in triaging patients. So if you know patients that require high NPIS scores are going to ultimately end up in the PICU, you might preferentially choose to place them there first. And the author's take-home message here, and I think it's a good one, is that the use of NPIS can have a positive impact on understanding where to place patients and the intensity of therapy that may be needed to treat their illness. And with that, I am done with this review and would be happy to open it up to questions.
Thank you, Dana. Wonderful job in really providing an oversight of that study. Very detailed, a lot of diagnostic components of the data that we saw. There are a couple questions and some coming in. I guess the thing that really sticks out to me is that, protocols and some type of validated score are very important in pediatric asthma. I think we have seen that over a period of 2 or 3 decades now. It helps standardize care and really focuses on 90% of the population that move through those protocols, those standards of care quite nicely. It's at 10% that then all of a sudden you need to throw the kitchen sink at, if you will. Things like high flow, things like non-invasive Heliox and mag sulfate. And I think you did a really nice job of pointing out in this study that that is probably the next wave or the next phase, because I think we've seen very nicely in this data and others that it is very predictive of length of stay. PICU length of stay, if it's used in a PICU, the amount of bronchodilator intervention. But it was interesting when you looked at the data, and you kind of called this out a little bit, that when you looked at clinician judgment, so to speak, and again, you got to be at the bedside, you got to see these patients, but when you looked at the things that were clinician judgment, which were non-invasive ventilation and high flow nasal cannula, those didn't necessarily correlate well with the modified pulmonary index score, in theory, thinking that the higher that score would be, those more technology, invasive, non-invasive, if you will, therapies would have been used in those patients, but it was used in some of the mild patients. And again, maybe it's anecdotal, but what do you think that you saw in this study, or what's your opinion from what you see in your own institution?
Yeah, thank you for that, Tim. I would agree. I think that anytime we have the opportunity to standardize, either with a guideline or a true therapist-driven protocol, we reduce the likelihood that we're either going to underutilize or overutilize our resources, right? So sometimes we get a really excited physician that wants to throw the kitchen sink at them early on, and other times we end up with a very conservative provider who might want to wait a little bit longer. I think we've all been at the bedside kind of tapping our foot saying, okay, come on, when are we going to put them on the BiPAP, man? And kind of wondering when that's going to happen. So I would agree. I think this demonstrates, again, that standardized tools really can guide care and ensure that we're making really clinically sound decisions for our patients. And when you introduce variables that are not standardized, again, in this case, the higher levels of respiratory support and intervention, high flow, non-invasive, and Heliox, that's when you start to see variability. And I think, when you start to think about that, then I think about overall utilization of resources. So we've been talking about this a lot with COVID-19, but, are our respiratory therapists where they need to be? Are they providing therapy that's unnecessary and we're allocating our resources in the wrong place when another patient potentially could benefit from their services in a greater intensity? or are we underserving other patients that really do need our help and ultimately preventing even more intensification that might be required because we waited too long? So I've seen this at every institution I've ever worked at. My suspicion is those on the line have as well. So for me, this really just intensifies the call for being thoughtful about standardizing where you can and following that 80-20 rule, as you mentioned, and trying to reduce variability at every turn when you can do that.
I almost laughed at one point there in your statement because in 1998 we published in respiratory care a study on our asthma protocol for pediatric patients, and one of the final conclusions was that any intervention that adds variability that actually does not improve outcomes but adds cost is probably something that shouldn't be done. So at that point we used that protocol to stop x-rays because we know what we're going to see: hyperinflation with bilateral infiltrates. No need for a full lab panel because they're asthmatic patients. And if they actually have an O2 requirement, then you may want to investigate if they have a pneumonia, chicken or the egg. Did they get the pneumonia first and then develop an exacerbation, or vice versa? But there were a lot of things that were variations in care that added cost but not impacted any of the outcomes. So I think, again, 20, 30 years later, your point is very valid. So here's an interesting question. I'm going to step back and let you have at this one. How would you go about, I almost said pressuring, that might be the right word, but presenting using a modified pulmonary index score to physicians to implement its use in a facility? And how would you encourage RTs to use it, since it would create an extra step more time to document?
Okay, so I'm going to start with the RTs because I think that's an easier one to answer sometimes. So I would agree, anytime you're presenting something to a team that is really busy, I mean, let's face it, respiratory therapists are always very busy. So asking them to do more work can be a big thing. I think with a tool like this and any protocol is to talk about the work up front and then the elimination of nonsense therapy later. Right. So we're going through this at my institution as well. We're very busy as a team. And so talking about taking additional time to do this new assessment and this new tool and the documentation associated with it and all the work that goes into dotting your I's and crossing your T's to be able to run a true therapist-driven autonomous protocol can take time. The benefit is, again, that you get to spend your time with the children or the patients that really need our services, while not spending your time with the children that don't. So it's really about reallocating resources, again, to the children that really need us. So, I talk to my team a lot about, why do we come to work every day? And we come to work every day to improve the lives of the children that we serve. And so this type of thing really gets to that. It puts us in the room. It puts us at the bedside of those kids that truly needs us, and lets us not to say waste, but spend time in areas that aren't necessarily as needed. So I think that's the sell to the respiratory therapist. Perhaps if you're getting rid of nonsense therapy, you can have a longer lunch break, and have some time to go to the bathroom, maybe, these really important things. And then for physicians, I think it's the same thing. I think there's a lot of discussion right now around cost of care. This might be a really opportune moment to mention something like this. I'm not aware of any hospital in the country right now that isn't acutely aware of the cost of care and what they're spending, particularly related to all the things we've seen with COVID-19, in addition to being thoughtful about where we're allocating resources, so our respiratory therapists in particular. So instituting a standardized protocol that can streamline care can reduce cost. We know that. That's been well studied. And it can also ensure that our resources, again, are where they need to be. So I actually think now is the time to strike and talk about this stuff, because I know our physician teams are listening, our executive leaders are listening, our finance teams are really, really listening and looking for ways to reduce cost and ensure our people are where they need to be.
Yeah, and I think that's a great point, and you're right. It's been validated in the data, Dana. When we did our score and study, we published it, and there was a lot of resistance to additional steps, additional work, but we stuck with it. We ran a study with patients on protocol and those that were not put on the protocol, and what we showed is that the average number of treatments for a pediatric patient went from 16 to 10. 10 being on the protocol, 16 for kids that weren't. That also came with obviously more treatments, a longer length of stay, a higher cost per care, and all of a sudden it became not an issue anymore. It was something that had to be done because you're right. We spent the time with patients that were sicker and needed it. The kids that actually had a mild to moderate exacerbation were treated and moved through the protocol quickly and were discharged. Nobody wants to be in a hospital. On the flip side, and this is going to delve into another question, Regis McFadden did a study in the emergency room using an asthma protocol in adults. And so what they did is they had a period with no protocol. They tracked the outcomes. They ran protocols for, I think it was like 3 or 6 months. And then they said, okay, we're just stopping the protocol. Do what you want to do. And so what that was kind of a post-protocol to see where the outcomes would go. And lo and behold, all the negative outcomes that you don't want to see, longer length of stay, increased admission rates, more treatments, variance in care, disappeared with the protocol. And as soon as they took the protocol away and stopped it, everything went back to the norm. So again, it's that variation in care that you hit upon. The question I'm leading into is, has there been any study that has used the MPIS, the Modified Pulmonary Index Score, in an adult population in the emergency room?
So that's a really good question. And I think largely this has been studied in kids. The traditional pulmonary index score is what this is obviously based on, modified pulmonary index score. The pulmonary index score was first designed for adults and was later modified for use in children. I would be honest to tell you that I am not super aware of a lot of articles that are published specifically for adult asthma using the MPIS. I will also transparently tell you that I didn't spend a whole lot of time in my literature search looking for that. So I would say, to my knowledge, no, but I would also say that I don't know that to be completely true.
Yeah, I'm going to tend to agree. I'm biased much like you. I came from a pediatric setting. So, I'm very familiar with the score and the modifications to make it a little bit more user-friendly. But I can't recall, nor did I really spend a lot of time looking to see of its use in adults. But again, I think if you went out and did a web search on adult asthma scores, there is probably something similar in the adult world. The big variation here is if you go back to the score or the page where Dana had the score, it takes into effect a variation of heart rates over age ranges. So that in itself is kind of the modified piece of that would invalidate it in adults, because while you may actually think that a younger kid with a heart rate of 115, 120 is normal, we'd probably be freaking out if that was an adult sitting in front of us with that same heart rate. So again, I'm sure there are adult asthma scores out there that have been validated, but I don't think the modified pulmonary index score has been used because of that tweaking of the heart rate.
That's a good point, and probably more the regular pulmonary index score would be more viable.
Yeah, and that may have been used in adults, and that's why it was modified for a pediatric standpoint. I think the next question I want to touch on is something that you've briefly mentioned, but maybe we can come back to it since we have a little bit of time here. Any suggestion by investigators or thoughts of your own about how the MPIS score could guide management? For example, severity score declines, perhaps you could start education caregivers using inhalers, controller medications, etc. So again, it's this concept of not just using this score to determine if the patient's mild, moderate, or severe, and certain caveats, but could it or should it be looked at to be used to guide management in other areas?
So resounding yes, yes, yes. I think that's so important. So I've worked at a lot of different children's hospitals, and we've all had different standards for when this type of education should begin. Some places that, if you're on continuous albuterol, don't talk about it. When you hit this score, this is when you should talk about it, et cetera. And I think so the overarching goal here is to ensure that you're starting education and discharge planning early, right? That's the mantra. But, you should start discharge planning the moment they hit the door. So when they're ready to go, they're ready to go. The flip side to that is you may not be able to have a good education session with a caregiver and a child while they're still very intensely and acutely ill in the pediatric ICU. So if you think about a kid who's on non-invasive ventilation with Heliox running through it or on continuous albuterol, they may not be in a position to really hear you and take in that education. So it becomes about determining when they're ready for that education. And I think every organization does it a little bit differently, either looking at the intensity of therapy or the score. But I do think there should be a trigger at which you start doing that home education, and whether it be spacer training and just true asthma education, and what are your triggers, and talking that through, and moving them into ensuring that their insurance is going to cover the inhaled corticosteroid you're about to send them home, so that doesn't delay discharge, et cetera. So yes, I do think that that is a great rule of thumb. It also helps the respiratory therapist know when it's time. So when that trigger fires, you can set that as a task that needs to be done by that therapist or by oncoming shifts.
So I think we're getting close to wrapping up here, and I'm looking at this conclusion slide, and it's something else that I thought about, and we see this probably more, I think, in a pediatric population than the adult world, the use of continuous albuterol therapy for asthma patients. But one of the things that you highlighted here was that this score was associated with increased time on continuous albuterol. And one of my pet peeves in the early years is that we would put patients on continuous albuterol and then kind of ignore them for a period of time. And so in your institution, Dana, I'm pretty sure that you guys are using protocols. Do you still use protocols on patients on continuous albuterol where you're evaluating them at a frequency or something of that nature, as opposed to just kind of letting them hang out for a period of time?
Yeah, we absolutely do. So our asthma pathway exists in the ER, on the floors, and in the PICU. And we actually do continuous nebulizers everywhere, including on the floor, because our PICU is often so full. But yes, so those kids are monitored Q1 by the nurses, and at a minimum every 2 to 4 hours by the respiratory therapist. And so we don't use the NPS, we use a different scoring tool, but the same idea. They're scored and transitioned off continuous albuterol as soon as they can be, based upon that objective scoring tool. And I would imagine at the Authors Institution for this particular paper, they do something similar, because you're right, that's a big pet peeve of mine as well, where they get put on continuous albuterol and it's quote unquote easier perhaps to manage them that way, and they sort of get stuck in that phase of care. So I think it's a good point. It's actually something we monitor very, very closely at my organization. And for us, we sit at about an average of 10 hours on continuous albuterol. And when we see that tick up or tick down, we do some re-education.
Great. Any final thoughts or words before we go to the wrap-up?
Again, thank you for having me here. I think this was a really well-written and well-thought-out study that, again, demonstrates that protocolized care is tremendously beneficial in respiratory therapists when in a position to make decisions, make sound decisions for our patients that allocate resources in the right way. And this particular scoring tool seems to be very beneficial in facilitating that.
Well, Dana, thank you again for joining us today. And thanks to all of you in the listening audience that attended today's Respiratory Care JournalCast. Be sure to join us next on October 1st for a discussion on the impact of COVID-19 on sleep medicine with Ms. Jessica Sweller. And again on October 16th for the October JournalCast with Dr. Jay Lee. Thank you again, and have a wonderful day.
All right. I think that's all for today. Thank you to our speakers for sharing their expertise, and thanks to our participants for interesting questions. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of the browser window. To note, the AARC offices are currently working remotely. If you have difficulty submitting credit after the event is concluded, please email crce@aarc.org instead of calling the main office telephone number. Thank you, and we hope you have a great afternoon.